no question there are challenges, and one of them is the Child-Pugh patients, and can we give them sorafenib or not? And Richard, I would like to hear your experience on that.
So this goes back to something we talked about in the context of local ablation and earlier therapies. And there's two questions. One, can you give it, and does it make a difference? Mm-hmm. The concern with the Child-Pugh patients is their liver dysfunction, regardless of their cancers, their liver dysfunction what's going to cause them to get sick and ultimately die of their disease. And I think when we're looking at Child-Pugh, we know they don't do as well as the Child-Pugh-As, but it is a fairly heterogeneous group of patients. Because Child-Pugh was not designed, as you discussed earlier, to assess patients for clinical oncology interventions. It was designed for portosystemic shunting. So the Child-Pugh patients are heterogeneous, and I would say if someone can come to the clinic and make follow-up appointments, then I'm comfortable giving them a trial of sorafenib. I have had patients who tolerate it well within that group of patients. I think work you've done in the initial phase 2 looked at Child-Pugh patients and showed that they can tolerate it. There is an increased incidence of some of the toxicities, but again, applying the same approach to the Child-Pugh, seeing them frequently, monitoring them, we can give them a trial of the drug.
Fair enough. Yeah, please go ahead. Amit.
Yeah, I was going to say, I think Richard hit on a major point, is that Child-Pugh is a heterogeneous group. Correct. Just like intermediate stage HCC is a heterogeneous group, you can have a couple lesions, or you can have 50 lesions, or 20 lesions. I think Child-Pugh goes from a score of 7 to 9, and so you can have patients who are Child-Pugh with some mild ascites and a mildly low albumin, and that patient's dramatically different than the Child-Pugh patient who has massive ascites and a bilirubin of 2.9. And so I think that it's really taking a look at which side of that Child-Pugh because it's a big bucket.
Yeah, and to add on that, what's very important, not only in liver cancer, but other oncology indications as well, but especially in liver cancer, is performance status.
Yes.
And I think performance status and Child-Pugh are likely intimately related. Yeah. But if someone, as I said, has a performance status of 1, even though their Child-Pugh score is 8 or 7, that patient probably deserves a trial of treatment.
Fair enough. Actually, to summarize that, there has been data in regard to Child-Pugh, as Richard mentioned. We reported in the as a retrospective work from the phase 2 data that was previously reported JCO on sorafenib, but later on there was a CLGB study, 60301, first author Anthony Miller from Wake Forest, that looked specifically in patients with organ dysfunction and the use of sorafenib. And that population, which was close to about 130 patients or so, had an ample number of patients with HCC, I believe 30 plus. And we noticed that bilirubin, which is below 1.5 upper limit of normal, you pretty much give the full dose. Bilirubin 1.5 to 3 upper limit of normal, you probably give half the dose, i.e. 400 milligram daily as a total dose. Bilirubin of 3, probably there is a safety concern here not to apply the drug. And phenylalbumin, which is less than 2.8, probably 200 milligram daily. And that's definitely is a good guidance one way or the other to help you out in managing patients. But again, it does not mean, and we heard it from the experts, that you should give up on a patient the minute they hit an Child-Pugh, because first, as we heard from Dr. Singal, this might imply different things. And number 2, the data has shown that you probably can apply a certain adjusted dose of sorafenib in that specific population. With this said, we spoke about prognostic markers. We spoke about radiologic markers with Ricardo. Interestingly, and you recall we know this from some other data in different cancers, but Richard, if a patient has some side effects like hand-foot syndrome or develop hypertension on sorafenib, does it mean they're going to respond better?
From my experience, I would say no, and I think we have a fair experience, and I think there's not a lot of strong literature that suggests that. There was an abstract at the GI ASCO meeting this past year that from a single center seemed to suggest that maybe if they did develop those toxicities, that they might do better. That is more of a biomarker or a pharmacodynamic effect, right? It doesn't tell us for the patient sitting in front of us, will they or will they not respond to sorafenib? So that type of data, I don't know how useful it is. Again, based on all the clinical data we've had for a patient who walks into clinic with advanced disease, sorafenib is indicated. Whether or not a month later they develop hand-foot skin reaction, that wouldn't be a reason not to continue if they're doing well. I mean, I think there's probably a certain bias that the patients who don't develop those side effects actually stay on drug longer, right? And they tolerate it better. So I don't think that type of data is ready for prime time.
Well, if anything, this data probably just suggests to us that, yes, we are eager to know how people might respond or expect them to respond. But if anything, it reminds us that patients who have side effects, of course, we have to manage the side effects. We have to take care of them. But at the same time, we should not give up on them as being not necessarily doing well after we manage the side effects from the treatment. With this said,